Welcome to the Mindvine podcast, where we challenge the stigma associated with mental illness through conversations about a variety of issues impacting mental health. Here we bring you news, views, and interviews that intrigue, educate, and celebrate recovery. Leading us on this journey are the hosts of the Mindvine podcast, Darryl Mathers and Chris Bovie.
Start off, I want to welcome to the Mindvine, our virtual podcast. During the pandemic, we're set up in different locations, and I want to introduce Chris Bovie, and my co-host is Darryl Mathers, and we have a very, very special guest, very fitting for Mental Health Awareness Week, Dr. Paul Kurdyak, who's the clinical lead for the Mental Health and Addiction Center of Excellence, also a psychiatrist and clinician scientist, medical director for performance improvement at CAMH, and also director of health outcomes performance evaluation for the Institute of Mental Health Policy and Research, and
wow. That's
just part of it. So now the show's over. We don't have any time for questions, but anyway, I want to thank you, Dr. Kurdyak, for joining us today during this special week.
It's a pleasure to be here. Thank you for having me.
So first of all, obviously you're working through this pandemic, much like healthcare workers, across the globe. Before I ask you our first question, I just want to say a shout out to all the healthcare workers who are, doing such great work during this and seeing us through this as a community, as a province, as a country. And for us, being housed on Ontario shores, thank you very much to our people back at our hospital who are there every day caring for our patients, much like other mental health hospitals in the province. So with that out of the way, first of all, how are you doing? How are you coping with this dramatic change in both your professional and I'm assuming your personal life?
Thanks for asking. I think I'm experiencing the same sort of dramatic impact on my life and work life as anybody else. I feel incredibly fortunate that I have this role with this new agency. It keeps me busy, and I feel like it gives me really something to focus on that feels meaningful. And but every day, as you pointed out, every day I feel for hearing all the stories about people struggling to work while they're trying to take care of their kids, people losing work. So I just feel fortunate, but as well as feeling fortunate, I feel a tremendous sense of urgency about having to work with, partners like Ontario Shores to be ready for what everybody's talking about, the second wave of the pandemic. And so, I would say fortunate, mildly stressed, and personally, and significantly stressed provincially. My summary statement.
So Ontario's gone through some really radical transformative change in health. And so, we've got the formation of Ontario Health rolling in, Health Quality Ontario and Cancer Care Ontario. Maybe if you could help a little bit for sort of the general public or the layman, the creation of the Center of Excellence for the Mental Health and Addiction Center of Excellence. Can you explain a little bit about what its mandate and role is and how it fits into health?
Yeah, sure. Thanks for the question. Just to further your description. So previously, we had Cancer Care Ontario, which was much more than cancer for the general public. It oversees standards and delivery of care for not only cancer, but for renal care and lots of other sort of work that they did for the healthcare system. Wait time strategy was Cancer Care Ontario, and then you have Health Quality Ontario, which is more of a quality improvement shop for the province, and then you have the LHINs, which are the 14 LHINs overseeing healthcare in the 14 different regions. All of that is now in one roof, and that happened with the Ford government. There's and in addition, there's other things being pulled into the agency, but there's one new agency, and that's what you mentioned, the Mental Health and Addiction Center of Excellence. I think this is incredibly important for our sector, our mental health and addiction sector, because it positions an agency within Ontario Health in a way that signals a kind of equity and importance of mental health and addictions as a priority in parallel with the rest of the healthcare sector. So symbolically, I think it's really important that the agency now exists. And really, I mean, if you think about what Cancer Care Ontario has done for the cancer system, I mean, we forget because it's it feels like a long time ago, but cancer used to be a highly stigmatized illness, and the cancer care system used to be quite a disaster. And it was all distributed. There were no standards. We didn't measure outcomes, and you could get very different treatment and very different outcomes depending on where you lived in the province. And 30 years later, or 25 years later, cancer care in Ontario is amongst the best in the world because of this systematic oversight, and really that's what we intend to do with the agency, is emulate the kinds of work, and it's hard for the general public to understand, but if we extend the cancer analogy, when somebody's, first of all, cancer is usually detected in primary care settings. Your family doctor, you go, something feels wrong, and there's some initial tests, and it's like, it looks like there's cancer here. And then you kind of get swept into the cancer system. And then there's like evidence-based testing to figure out what your stage is, which is another way of saying, how severe is your cancer. And then your treatment slots in an evidence-based way, depending on what stage you are. And then you're followed through, you're constantly monitored as to how you're responding to treatment, and things happen in an evidence-based and measurement-based way. And if we think about what happens in the mental health sector, when I work in downtown Toronto emergency department, a psychiatric emergency department, and what I hear from people in Ontario is either I don't know where to go or I couldn't wait. And so that to me tells me that there really is no meaningful system for mental health care in Ontario, certainly not in the way that we would think about cardiac care or cancer care or other areas of the healthcare system. So it's a daunting task to think about how to create systems of care delivery for mental health and addictions. And I think we're going to have to be quite focused at the beginning in certain areas so that we can actually achieve some of the things we hope to achieve. The cancer care system wasn't built in a year. It took 25 years to get where we are today, and I think but this is the first step, and we feel it's a really important step, and it's a step that it's not just about the agency. The agency, we feel, is a coordinating center that plugs in all the leadership that exists in Ontario Shores and elsewhere.
And just thinking about the cancer care model and how it may relate to mental health, in Ontario, we're so geographically spread out across the province. So I wouldn't even say that, sorry. We have highly populated areas in Ontario that are fairly close together, and then we have this wide range of rural areas. And so stigma is obviously a challenge, as it was for cancer decades ago. As you look towards maybe some of the challenges, how are we going to overcome geography? How are we going to overcome stigma? How are we going to kind of create a system that's more mental health centric?
Yeah, so the stigma piece, there's stigma and then there's geography in the context of access. I think there are two sides to your question. And I think the stigma piece, we're already seeing it unravel in heartening ways. So one of the aspects of my work is at ICES, which we use big population-based data to monitor trends. And we see very clearly a generational change in the likelihood that individuals will seek help. And more specifically, we look at rates of mental health and addictions related emergency department visits by age And the 16 to 24-year-old age group is seeking help at a far higher rate than those that are older. And they're sort of going forward. So I think, I have two kids, 18 and 20. They don't experience stigma of mental illness in the same way that I do, and certainly not the same way that my parents did. So I think that there is a generational shift in stigma. It's an interesting question about whether that plays out rurally. In other words, is the stigma of mental illness different in a large urban setting compared to a rural one? I don't think we know the answer to that, but I'm guessing the answer is yes. So there are probably some health promotion activities that should be associated with that. But the geography piece is a tougher nut to crack, because I think stigma is just happening anyways. I believe we're in the midst of this public mental health moment that's kind of not going away. But geography is really challenging, and so the two things I would say about that is that because the agency is within Ontario Health, some of the public may be aware of the Ontario Health teams and the ways in which these Ontario Health teams are being explicitly laid out in regions of the province. So we are keeping a very close eye on the evolution of the Ontario Health teams and how they are being distributed regionally, so that we can capitalize on those sort of access points for care more generally and piggyback onto the many mental health initiatives that we have. But the other big piece, and this would probably ring true for your hospital, certainly CAMH and any other mental health service provider, this pandemic has put the pedal to the metal as it relates to shifting to virtual care, right? So we've been monitoring, my ICS team have been monitoring the use of telepsychiatry to increase access to areas where there's very little in the way of mental health services. And it's been pretty slow, and it's a kind of a drop in the bucket. But I don't think we're going back after the pandemic. And so one of the things that I'm really looking forward to and excited about as it relates, the silver lining of a pandemic is that it may have forced innovation in ways that we can capitalize on to address some of the issues you're talking about, which is, we may not have to persist with virtual care in Whitby or Oshawa or Toronto, but the capacity may persist so that we can serve, areas to the north and some of our more agricultural centers as well.
Dr. Kurdyak, I know even before the Center of Excellence, you had a good lens on the mental health addiction system and was an advocate for things like, provincially funded sort of early intervention and care, right up to standardization. So what do you think are the biggest gaps in the system? Because we do have, again, there's a multitude of mental health and addictions agencies. When you walk in the door, you may get something different from each one. And how hard is it to bring that together? And what are maybe some of the other bigger challenges that you face?
Yes, that's a really good question. And I think that there's a tendency in the midst of these kinds of crises to sort of respond reactively. And people are talking about, this pending mental health crisis, but the problem is we've always had a mental health crisis, not so much because, mental health, like the prevalence of mental illness has been pretty stable, but we just don't have a system to support demand prior to the pandemic, and it's only going to get worse. So, thinking about, well, we should be doing, X or Y, and we should be funding X or Y. What we've been thinking about is, to your point, on the one hand, there is a significant amount of funding each year that goes towards mental health and addictions. It's not enough, but it is significant. And there's about $4 billion a year that the Ministry of Health pays for mental health care in Ontario. And I don't think anybody would say that we have a good read on how that money is spent, what outcomes we're achieving as a result of that. So I think step one is to wrap our heads around where that money is going relative to need. So we probably should get a provincial read of need and then figure out where the investments are going and then do the tough job of realigning investments with need. That's at a very macro level. I think that's step one. Step two is related to the other aspect of your question, which was really good, is and related to the specific aspect of, people might get something very different no matter where they went. And there is critical, what I would call core infrastructure, no matter what you decide to do, that we need to build. So when we talk about regions in Ontario, we should probably think about some sort of centralized access structure or function in each region that allows people to have a one-stop shop that then distributes individuals who have mental health and addictions needs to regional care. And that does a lot of things. One is that, like the cancer system, it allows the opportunity to systematically vet what the individuals need and make sure that they go where they need to go, versus this scattershot approach that we have now, where people may go nowhere, they may go where they don't need, they may get more than they need. So right now, that's the first step of the system is this centralized point where people, we really do a good job in a standardized way of figuring out what people need, and then we work with them to get to where they need. And that also serves a second purpose, which is it allows us this centralized opportunity to collect information on our regional population so that over time we can learn the needs going forward, and we can learn how we're doing in terms of getting them to where they need to do the course correction and resources. And then the third piece is whatever we do in specific areas, like right now we have a provincial, it's now called Mindability, the Structured Psychotherapy Initiative that Ontario Shores is participating in. Whatever we do, and that's one of the big investments that we're working on, we are mindful not only of standards and quality and good quality improvement processes around that specific initiative, but we're also mindful of using these initiatives and the momentum associated with them to build that core infrastructure, so that when we expand Mindability to the province, start investing in these centralized access hubs, so that when Mindability is up and running, we can use those centralized access points for the next thing, which might be addictions care or early psychosis intervention or what have you. I don't know if that makes any sense, but there's sort of like...
So do you think, not to put you on the spot or that, but when we look at the system of places like KMH and that, do you see their role or specialty role for that central intake to support? We've moved to these sort of Ontario health teams regional, but then you have these provincial or larger players. Do you see a role for them in that kind of expert intake piece, or how do they fit in?
Yeah, it's a really good question. So I think that it's that centralized access role will change, and even the process of it will be regionally different. So in less sparsely populated areas, it may be more virtual, right? Like because you don't want people to have to travel all over the place. Whereas in urban settings, when people took transit, people can get to places. So I think right now we are agnostic about where and the how, but we are very clear about what needs to happen. We just I think there's too many moving pieces in terms of the evolution of the Ontario health regions. There's no OHTs, and we want to work in lockstep with them. So I feel like I'm kind of dodging your question.
That's okay. No, it still works.
But I feel like it's a bit too early. I mean, I think it's a pragmatic combination of what resources are there and where is the rest of the healthcare sector going. Because what we don't want to do is we don't want to silo mental health and addictions from the rest of the healthcare sector by creating parallel systems. That's both inefficient and it's historically done our sector a disservice.
Right. Just one last sort of follow-up, Darryl. Sorry. The trick, the balance is, and you know this as well, and I've talked to Minister Elliott about this. So you've got the system saying, release money, we want to, there is a need, and there's a need for more service. But at the same time, when they came out with the road plan or the mental health plan to ensure that those resources are being spent wisely. And how do you balance those two, this urgent need, but building the system that makes sure the funds are going to the right place and getting sort of the best results for the dollar?
Yeah. So I think that is already emerging as our attention, that we feel like there's a short-term urgency that there and there's a political need to address those. But as you're kind of implying, the kinds of infrastructure course corrections that we're talking about don't happen in months. They happen over time. So I would say that the advantage of having an agency is that the advocates will continue to go to their MPPs, who will continue to roll stuff up to Minister Tabolo and Minister Elliott. We have this agency who steadfastly focus on the job at hand, and the second piece to that is that when you go about making these targeted investments, that the sector works with the agency, because we have the expertise and the resources to overlay a provincial measurement strategy. So to address the second point, which is, even if you do go ahead with investments, how do you go about it in a way that's responsible? I mean, I think that's essentially what you're saying. How do you make sure that the taxpayers' money goes to good use? And I would say that the healthcare workers, I don't know if the Ontario Shores is involved with that. The healthcare workers' COVID response is an example of that. We, in 2 weeks, we work with our partners, Ontario Shores being one of them, to create a system of self-referral care for healthcare workers who've been and frontline workers who've been affected by COVID with respect to mental health and addictions. And one of the critical things that the agency did was work with the partners to create a kind of a minimum rough data capture aspect so that we can monitor things weekly, because we have no idea what demand will be like, and we want to be able to respond accordingly. So that I mean, you don't want to do two things. You don't want to invest a ton and find out that there's no demand, but you keep things going just because. And you don't want to miss a crisis. You don't want to announce something and have it not meet needs. So, yeah.
You mentioned a little while ago just about the kind of the generational shift in terms of the demand for mental health services and how that's going to continue.
Yeah.
And with any monumental shift, you need time and you need support from society, and it needs to be valued by society. So, in the midst of this world that we're living in, where the 24-hour news cycle is COVID-19 and the pandemic, how have you felt about where mental health has fit in terms of it being discussed in the media or social media or among friends, or how do you feel about where mental health has been in this larger conversation that is the pandemic?
Yeah, I'd be interested to hear what your opinion of this is, but I'll tell you what I think. I think even before the pandemic, and if we take sort of a geological scale, and I'm old enough to take geological scales, so I would say from the time I became a psychiatrist to now, the degree to which mental health issues are covered in the media has increased exponentially. I would say that when I finished residency, being a psychiatrist was a source of shame within the medical community, and you hardly heard about anything related to mental health. Now it's very common to see stories on a weekly basis, sometimes reaching the front page of major media outlets, and covering that. That said, we are definitely seeing issues within the agency, within the Center of Excellence, that suggest a misalignment of attention. And one example would be, there's a very, within the pandemic, initially there was a real urgency around critical care and ICUs, and then we realized, the province realized that long-term care was where the crisis was actually occurring. And we found it very difficult to ensure, at least at the beginning, and there's been a course correction since, to include, congregate living that is mental health and addictions related, like group homes, supportive housing, any pandemic related issues that have implications for long-term care also impact these congregate living areas. So that in other words, they're just like long-term care, except that they're housing vulnerable individuals with serious mental illnesses. So that's an example, sort of right now, where we felt that there was a misalignment, that we weren't included in a conversation, even though the subject or the issue was very relevant to that aspect of the kind of work that's involved in our sector. And then the last thing I would say is that I feel like there is a lot of discussion about the stress that this pandemic has had, the long-term economic consequences, and it comes out in weird ways, like the concern about domestic violence, the impact of unemployment, and what toll that's gonna take on mental illness and addictions. I mean, we have people who have time are laid off, and LCBOs and beer stores are essential services. I mean, that's for those who are sort of sub-threshold having a drinking problem, that's a concern of mine, that this is ripe for stress plus time plus access. For those who had sort of problematic drinking now might be in more trouble. So these are just things that I'm thinking about and worried about. But I feel like the media is there, and I think that it's going as the actual infection-related aspects of this pandemic subside. I think we're going to see a shift more towards the mental illness consequences of this. But what do you guys think?
I would. So on the media side, I've actually been impressed with how quickly the media kind of took it as this is going to have an impact. Like the health implications are more than just COVID-19 and that particular illness. So it's been interesting to watch that and it grow. I mean, I think it's still, and I'm sure Chris has a similar opinion, is it's still very much an acceptance of mild to moderate mental health issues. Right. And I think the people with more critical illnesses, they're not benefiting from any stigma reduction in this situation. But it's been enjoyable, or at least rewarding, to see like, hey, they, without any prompting, they have picked up on the fact that this is going to impact people's mental health.
Sorry, go ahead.
No, I would agree. And I've always said kind of the difference between cancer, like the more ill you get, the more empathy you have when you have cancer. But with mental illness, it's different. People seem to have more empathy or understanding around anxiety or the mild things. When it becomes schizophrenia or something like that, then they have less empathy and understanding. So, or more stigma.
Yeah. And I think that is very true. And that goes down to the congregate living situation. I mean, those are the individuals who are vulnerable that you're talking about, that are being overlooked, who are at high risk.
Just to follow up on that. Sorry, Chris.
Sorry.
Just to follow up on that, just because just popped in my head, and this might be stretching a little further, but do you have concerns about people who are losing loved ones during this time and unable to grieve like the way that they normally would? Like, is that something that we should be looking out for our friends and family that may have lost somebody, whether it's COVID related or not, during this time?
Yeah, I think that's one aspect of many sort of remarkable pandemic related stressors that we need to be concerned about. And so I would say that I mean, often my head hurts when I think about the implications of the pandemic. I mean, you can go down a million different rabbit holes, and what we've been really focusing on is how can we systematically monitor things over time so that we can go after issues as they come up. And that's something that I'm really, so in other words, don't measure a point in time and then because we can't predict how things are going to unfold. There's, we have to go back to 1918 and the Spanish flu. And I can tell you that probably 2018 or 2020 looks a lot different than 1918 in terms of our healthcare system, our social systems, etc. So there's no evidence to say help guide us as to how to respond. So I'm really thinking we need to be measuring on a really iterative basis so that we can react when we see things and go after them systematically.
I just wanted to close, maybe touch on something you brought up a little earlier when you talked about housing and that. So the Center of Excellence, well, it lives in health. We know success for people touches multiple ministries. So I'm wondering, when we look at justice, housing, education, all those, how engaged provincially is the Center of Excellence with other ministries for solutions, whether it's ODSP and all those factors that really are going to determine success for individuals?
Yeah, so that's a great question, and I would say that even before the creation of the agency, in my role at ICES, one of the first things we did when we established our shop was to start going after data from MCCSS, from the correction side of things, from education. The idea being that if you only look at mental health, which is what you're saying, if you only look at mental health from a health perspective, you are missing massive social determinants, consequences, and causes of mental illness, so that you really have a sort of a thin wedge of understanding. So I would say that historically, my sense is that when you get into issues that are interministerial, it complicates things because you have different budgets, different priorities, different political settings. But I do feel as though that's getting better. And I can tell you that we are doing some work. So I'm writing up a study now, looking at individuals in correctional settings and looking at their health use. 70% of people in correctional centers have had some mental health or addictions related contact prior to their correctional setting. So to your point, these things are entirely interrelated. Just think about ODSP and Ontario Works implications. And so, I think the for all, I think it's perhaps magnified in mental health for our agency, but for all of the healthcare sector, we all know about basic inequities that play out in determinants of health that'll impact health and mental health. So we are cognizant of that, but that's a complicated piece of work. Sure. But a great question.
Well, thank you very much for joining us in the middle of the pandemic, but also it's Mental Health Week. So thank you to everybody who works in mental health and who's been moving everything forward in the last decade. Or probably a little longer than a decade. Chris and I have joined the mental health field around the same time, and our experiences are very similar. It's gone from zero in terms of discussion to now. It's not uncommon to see it in an article or being discussed even at the family table. So, thank you very much for all you're doing to get us there and to get us further ahead. We appreciate it.
Oh, thanks very much for having me. It's a pleasure chatting with you guys. Take care.
Thanks very much.